Oh iya, saya telepon ambulan dulu ya.
Nomornya 085 Halo, apakah benar dengan keluarga saudara Tuan A? Iya, saya dari IGD RSUA ingin memberikan informasi bahwa suami ibu mengalami kecelakaan. Apakah ibu bisa ke RSUA sekarang di IGD? Iya, baik Bu, terima kasih.
Kita tangani pasien ini. Pak. Pasiennya ngorok. Saya kasih oksigen ya, 10 liter per menit. Tensinya 90 per 60. Ini nadinya 110 kali per menit, RN 30. Aku lapor dokter dulu ya. Iya.
Apa tadi ibu yang lihat kejadiannya?
Oh iya sus, saya tadi melihat kejadiannya.
Bagaimana kronologinya Bu?
Oh jadi gini, tadi kan saya pulang kerja, terus saya melihat bapak itu naik motor, terus itu apa kayak nabrak pohon gitu, jatuhnya tuh kayak kelungut gitu pokoknya.
Waktu kejadian apakah bapaknya masih tersadar atau sudah dalam keadaan pingsan?
Tadi sih kayaknya masih sadar, tapi tuh kayak nafasnya tersela-sela gitu, makanya saya langsung telepon ambulan tadi.
Oh, terima kasih untuk informasinya Bu.
Oh iya, sama-sama sus. Ya, ini kenapa ya tadi ya? KLR dokter, diperiksa dulu ya. Oh ini ada jejasnya. Iya. Nanti apa pemeriksaan foto ronsen ya? Ini ada fraktur basis krani enggak?
Tidak ada dokter, tidak ada di kamar kan.
Ya berarti ini nanti dipasang infus dulu. Ini tadi RW-nya gimana ya?
RW-nya tadi snoring dokter, terus saya kasih orofaringnya, sekarang RW bebas. NRM 10 liter per menit, saturasi oksigen 90.
Terus DTV-nya?
Tensinya tadi 90 per 60, tadinya 110 kali per menit dan RN-nya 30 kali per menit.
Habis ini distabilkan dulu ya tekanan darahnya, setelah stabil baru dibawa untuk foto toraks ya.
Aduh ya Allah, suamiku. Mas, ya Allah.
Permisi. Ibu ini keluarganya Tuan A?
Iya, saya di sini.
Ya, ini dari hasil pemeriksaan ronsennya bahwa Tuan A itu ada darah di bagian dadanya atau hematothorax. Nah, ini nanti akan dilakukan pemasangan BSD seperti itu.
BSD itu apa ya dok?
BSD itu kayak apa? Selang dimasukin di dada buat ngeluarin darahnya.
Oh,
Ya, nanti minta tanda tangan informasinya ya.
iya dok. Apa aja ya dok kalau lakukan buat suami
Iya.
saya dok?
Pemeriksaan itu. Benar ibu dengan Tuan A?
Bulan saya.
Ya, ibu Fafa ya? Iya. Ya, ibu Fafa. Apakah suami ibu ada alergi obat?
Kayaknya sih nggak ada sus.
alergi obat nggak ada. Kalau alergi makanan kayaknya nggak ada juga, karena nggak ada dia. Terus ibu tahu nggak makanan yang dimakan terakhir oleh suami?
Oh, kalau itu tahu sus, tadi terakhir tuh suami saya bilang itu dia bisa makan ayam dari nasi kotak.
Oh, makan ayam.
Iya.
Kasih ya informasinya.
Line posteriorly, which is also the anterior aspect of the latissimus dorsi, the apex just below the axilla, and the horizontal level of the nipple inferiorly. The nipple line may be an unreliable landmark for female patients due to breast tissue. To help with landmarking, remember that the triangle of safety should approximately lie between the 4th and 5th intercostal space in the anterior axillary line. Start your landmarking by localizing the clavicle. Next, count the rib numbers as your fingers traverse down the anterior chest wall. Once the correct intercostal space is found, move your hand along the space laterally towards the anterior axillary line. The incision will be made here. The chest tube will actually be inserted one interspace above this point. Mark the incision spot with the imprint of the back of a needle or a pen marking. Once full barrier precautions are employed, use the chlorhexidine cleaning solution and sterile gauze to create a large sterile field on the patient's skin. Cover the field with sterile drapes so that only the procedure site is exposed. Adequate analgesia is a very important step in this procedure, as chest tube insertions can often be very painful for the patient. The skin, subcutaneous tissues, deeper tissue layers, parietal pleura, and periosteal surface of the rib below the intended insertion site must be generously anesthetized. Using the smallest gauge needle, create a wheel of anesthetic in the skin overlying the landmark spot. Using the larger needle, anesthetize the subcutaneous skin layers through the wheel, aspirating as the needle moves deeper. Anesthetize the periosteum of the rib that lies below the intercostal space where the tube will be inserted. Once the parietal pleura is encountered, a flash of pleural fluid will fill the syringe if a pleural collection is being evacuated. If a pneumothorax is being drained, the syringe may only fill with air as the needle enters the pleural space. Withdraw the needle, aspirating along the entire path. Make an incision approximately 1.5 to 2 centimeters in length above and parallel to the anesthetized rib. Introduce the curved dissecting instrument, such as a Kelly clamp, into the incision. Begin dissecting the subcutaneous tissues in order to reach the intercostal muscles. After dissecting through the subcutaneous tissues, stay on top of the rib to guide the blunt dissection. This will create a diagonal path towards the correct intercostal space. When using a larger chest tube of sizes 24 French or greater, use your index finger to explore the tract being created by blunt dissection. This is done to ensure the larger caliber tube will be able to pass through the tract. Once you have dissected through the subcutaneous tissues and deeper intercostal muscle layers, you will encounter the parietal pleura. Push the clamp gently through the parietal pleura. The entry into the pleural space through the parietal pleura is felt as a give or a sudden release of resistance. Alternatively, you may use your finger to penetrate through to the pleural space. Once the pleural space is entered, use your index finger to ensure the lung is not adherent to the chest wall, which may impede passage of the tube into the pleural space. Often, pleural fluid will trickle out through the tract, further confirming entry into the pleural space. Pass the tube through the incision, unclamp the jaws of the Kelly, and then direct the tube through the tract slowly, using your finger as a guide. If the tube is meant to evacuate a pneumothorax, aim it apically towards the top of the lung. If the indication is to drain fluid, aim it basally towards the bottom of the lung. Make note of the depth the tube has passed by keeping track of the numerical markings on the side of the tube. Secure the chest tube to the skin using the heavy sutures. Simple interrupted or mattress sutures are often satisfactory to ensure stability of the tube and avoidance of air leaks around the tube. The free ends of the sutures are wrapped around the tube and tied multiple times to secure it in place. Purse string sutures are not recommended as they yield poor cosmetic results and increase the risk of skin necrosis. Once the chest tube has been secured, a petroleum-based gauze dressing should be wrapped around it. Apply several pieces of sterile gauze around the tube. Secure the site with multiple pressure dressings. A chest X-ray must be done to confirm correct placement. On an X-ray, the radio-opaque stripe is visible with an interruption indicating the position of the proximal hole. This hole must be within the pleural space. Otherwise, it is sitting outside the pleura and not draining effectively. This is an indication to replace the tube altogether. Do not advance the tube into the chest, as this can introduce non-sterile tubing into the chest cavity. Before unclamping the free end of the chest tube, firmly connect it to the sterile drainage system. Now unclamp the free end. If pleural fluid is being drained, the fluid level in the drainage system will rise. If a pneumothorax is being evacuated, air bubbles will appear. Do not reclamp the chest tube while there is bubbling. This may lead to recollection of a pneumothorax and may even result in a tension pneumothorax. Most commercially available drainage systems use the 3-bottle model of closed drainage and suction. The most important bottle is the underwater seal, which serves as a one-way valve that allows air and fluid to leave the pleural cavity without the risk of re-entry during inspiration. All available pleural drainage systems contain the underwater seal bottle. Bubbling may be seen in this bottle. This will indicate whether there is an ongoing air leak either from the patient or from the system itself. The 2 other bottles that may be present in the drainage system are a collection bottle connected directly to the patient for accumulation of pleural fluid.
Selamat pagi, Bu. Ini bapaknya sudah terpasang selang USD. Kondisinya juga sudah stabil, sudah melewati masa kritisnya. Terus SpO2-nya juga sudah 98%. Nanti setelah ini Bapak akan dipindahkan ke ruangan. Tapi kita masih menunggu kamar perawatannya terlebih dahulu ya.
Ya, setelah ini Ibu bisa izin sama saya di sini mengurus. Oh iya. Kasih ya.
Oh iya, telepon rawat inap dulu ya untuk Tuan A itu. Ya, halo dengan rawat inap. Ini dari IGD. Ya, ingin memesankan ruangan. Di sini ada pasien dengan hematothorax. Ya, keadaannya sudah stabil dan akan kami pindahkan ke ruang rawat inap. Ya, mohon dipersiapkan ya, Mbak ya. Ya, terima kasih.